You know what I already told you about pharmacology? It's going to be fine. You're going to have a lovely time. But you will work hard. I'm not going to lie. You will work hard, but it's going to be fabulous. You're going to learn all the drugs, all the things. It's going to be great. Okay, so I'm going to talk a little bit about drug diversion. So one of the things that is problematic in the world of nursing is what we call drug diversion. So does anybody know what that means? If someone was to say that to you, what would you think? People are typing. The nurse is keeping drugs. Now, is she just holding on to them, like close to her heart, loving them, warming them? What's happening? They're either taking them themselves. Sometimes they could, I guess, sell them, but usually they are diverting them for their own personal use. So, Braden, yes, it is an unattended effect because that person does not legally have the right to be taking those medications, and so that's not really what we would like to see. So this is what we're going to talk about. Okay, so here we go. So when we talk about drug diversion, we're really talking about prescription drug use, and this is one of the fastest growing problems in healthcare in the United States. And the CDC has actually come out and deemed it an epidemic, right? Because we have so many patients and families and healthcare workers and facilities that have been affected by this problem that the CDC got involved and said this is a major issue, right? And so basically, prescription drugs are the most common cause of drug diversion. And basically, this is where prescription medications are obtained or used illegally. So it's a really complex problem. There's a lot of pieces to the puzzle, so it makes it really difficult to try to prevent. And so it's up to us as nurses to be educated in what drug diversion is, what you might see if you're working with somebody who is drug diverting, and then how we are going to combat it. Like, what would you do in that sort of situation? So basically, when we're talking about nurses who are impaired, right? When you think about a nurse who's abusing some sort of illegal substance, right? This is something that is going to happen to the young and the old. It happens in all different cultures. It can happen in other occupations, but because of the close proximity that nurses have to these particular medications, it is higher. There's a higher risk among nurses than other professions. And so about 1 in 10, or about 10 to 15% of all nurses may be impaired or in recovery from alcohol or drug addiction. So alcohol is the most legally abused legal substance, and then prescription drug abuse is a close second. So why do you think that nurses, 1 in 10, I mean, think about your cohort has 40 people in it. Yeah, exactly. So so you just start picking off. No, just kidding, don't do that. But I'm just saying, so out of your cohort, there's a potential that 4 could struggle with something like this. So why do you think this happens with nurses? What is it about the nursing profession that causes people to abuse drugs? Yes, stress is a big one. Burnout, easy access, exactly, Braden. Trauma, yes, right? Not only in the trauma that we see and that we care for, but we also can experience trauma as nurses, right? Hard patients, work-related injuries, right? If you're hefting around, some 400-pound patient and you hurt your back, you're going to want something to alleviate that pain. And you might only be able to get, prescriptions for that for some time, but that doesn't mean that the pain has gone away. And so you have to figure out a way around that. It's an excellent coping mechanism, right? It kind of helps us forget and kind of escape for a little bit from the things that are happening in our lives. Long shifts, right? Those 12-hour shifts can be killer. And, if you're working night shifts, you don't love night shifts, exactly. So Alina, you're right. So not only are we working long shifts, but now we're working numerous days in a row. So we're not having that opportunity to kind of relax and recoup and kind of regain some strength to go about our, work for the next day or the next couple of days. I know, a day shift. I I'm not a fan of the day shift. Corby and I, we work together nights on pediatrics, and we have a grand time. The day shift, it's not really for me. So when I mentioned, I mentioned before that it's really for the nurse, it's the access to the medications that, put them at more increased availability, I guess, to become dependent. And then when we think about when a nurse becomes impaired, right, that is going to affect their ability to provide safe and appropriate patient care. So when you think about these things, like alcohol is a sedative, right? It makes you sleepy, it makes you, not react as quickly. And so think of how that would play out in a patient care setting. Would you want to be the patient who has the nurse who is impaired by alcohol who's caring for you? What if there's a code situation, or what if something has to happen quickly, right? Somebody falls and you miss the catch. Exactly, right? This is where the issue is of course we're concerned about the nurse and the harm that's happening to him or her, but we're also even more concerned about what's happening with our patients and the poor care that they are going to receive as a result of the impaired nurse. So, what does a substance abuse nurse look like? This guy? Maybe not. It could, right? But this has been going on for some time, right? This guy's kind of a hot mess. But for the most part, is he single? I'll give him your number, Kim. For the most part, you're not going to be able to easily recognize somebody who is abusing different kinds of substances because they take such great care to cover up and hide what's happening. So I wish it was this easy to have this guy come work on your unit and you're like, yeah, you look a little sketch to me, like what's going on, right? See, so maybe, right? This might be, this would be a great, physical cue to be like, whoa, something's going on here. Like, what can we do to help you? But it doesn't always, work out that way. He's winking at me. Okay. So this is a tough question that I'm going to ask you, and I want you to think about it. If you suspected that a nurse on your unit was diverting a medication, would you tell your manager? What if this was like your best work friend? Would you be willing to go to the manager and say, hey, I think that this is what's going on? So some of you are saying yes, a double yes. It's kind of throwing them under the bus, right? But patient safety is our first priority. And I would hope that when you go to talk to the manager, that it's not in a malicious way, that you're going because you want that nurse to get help if help is needed and to be able to keep patients safe. Like, you're not going to be mean or to be a jerk, just to stir up problems. You're going because you have a true concern. And, even if your accusation is incorrect, right? Maybe there still is something that's going on that could be resolved. And hopefully the manager will be able to use discretion when an investigation takes place, right? So let's talk about this comment that Kim said. Do you think it would be appropriate to approach the nurse? What do you think about that? Like, if you suspected somebody on your unit? I think that it's going to be very, relationship specific. Like Megan says, it would depend on your relationship, right? If you had an encounter with this person where you felt like something was a little off, maybe, they were wanting you to waste a medication and they didn't have the medication for you to see, and they were wanting you to, sign off saying that you had seen them waste it. You could easily say, I'm not going to do that. And if you ask me again, then I'm going to have to take it to the manager, right? So I'm just letting you know that that's not appropriate and you need to be better and those sorts of things. So you could ask them to go, but then they know that you're the one who is making the accusation. So if that's something that you don't want to have known, then you might want to not have them go with you, right? So it just depends. But you have to be willing to, have those uncomfortable conversations, just because it's part of our job. Okay. Okay, so I want you to think about these questions. So would you ever go to work after consuming alcohol? So how long does it take for alcohol to kind of dissipate from your system? Does anybody know? How many hours? It depends on how much you drink, right? Mark's saying 8.5 hours. And there are a lot of things that factor into it, right? Your size, how well you handle your alcohol, if you were eating food while you were drinking, all those sorts of things. But, you know, it's going to differ every time. So you wouldn't go to like a party and, you know, have some drinks and then go home at like 1 in the morning and get up at 5 to go to work, right? That wouldn't be appropriate because you're just not going to perform well. You're going to be, you know, tired, your reflexes aren't going to be there, your mind is going to be foggy. And so, you know, if you come to work, not only are you putting your patients at risk, but now your colleagues are in a weird bind because they're looking at you like you're worthless. Like, why did you come? You're not going to be a help to us. We can't rely on you if we get in a pinch or if we have a crisis situation, right? It's just not going to be a good situation all the way around. Yeah, see, that is so scary to me. I mean, I'm glad that he got pulled over and was arrested because could you imagine what harm he would have done? It would be insane. Okay, so let's talk about some myths that go around regarding drug diversion. So the myth is that impaired drugs only use street drugs. So are they out there on the corner looking for their next hit? They're going to their dealer, you know, taking their dollars over and saying, give me whatever you got. Usually not, right? Nurses, substance abuse nurses are usually going to use medications that they have access to. So they might incorporate some common street drugs, right? Like if they feel like what their hospital is providing for them or they're able to get at the hospital isn't really working, they might mix it up with some street drugs. But, you know, they will most likely start with what they have available to them. So, you know, maybe they will, you know, start with like Demerol or morphine or codeine or things like that. But even though those drugs are considered legal, if you will, they can be just as harmful as illegal street drugs. The myth is that combining drugs is not harmful. So if I choose to take, you know, like a Xanax and some morphine because I'm just kind of stressed and, you know, I'm having kind of some pain, that's not really that big of a deal, right? Wrongo. When we choose to combine different classes of medications, which you will learn about in pharmacology, you know, if we combine an opioid and a sedative and things like that, that is just going to compound the effects of those medications and it's going to make the consequence so much worse. Impaired nurses have a long history of drug or alcohol abuse. Sometimes that's not the case, right? Maybe there was some sort of stressful event that just basically caused them to snap. You know, maybe they had a divorce or they were in a car accident or they were caring for a sick family member and they are just like, I cannot handle this anymore. And so they're turning to alcohol or they start diverting drugs as a coping mechanism to get them through that event. And then once the event has resolved, now the addiction is in place and so they have to continue to feed the addiction. Drug addiction is voluntary. What do you think about that? Do people choose to be addicted to drugs? What are your thoughts? No, yeah. It's not voluntary. Is there a genetic component that people are more susceptible to become addicted to medications? So there's a lot of research that's been done on this, right? There's been studies that have looked at like alcohol addiction and whether or not there's a genetic component in there. And so the only way that you don't become addicted is if you don't start, but you don't know that, right? Result of actions, right? Exactly. So sometimes, you know, people will participate with drugs just because of the thrill that it gives them or the feeling that they get when they participate. You know, sometimes they get a little rush from doing it. But then once they've started, they don't get to decide, I'm going to be addicted or I'm not going to be addicted. That's going to happen, you know, depending on how that patient responds. And so people need to be aware of that. right? Some families will say that addiction, runs in their family and that they have to be careful in the things that they do and things like that. And so if you know that, great. And so the best, scenario to avoid an addiction is just not to get started. Okay. Impaired nurses are easy to recognize. So we saw our little hairy friend there, right? It would be so nice if everybody looked like that. And you're like, ding, 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 there you are. There's our nurse. We're going to take him down, right? And you might notice certain signs and symptoms that we're going to talk about in a minute that you're like, oh, that seems a little sketch to me, like there could be something going on. But usually, like I mentioned, these nurses are smart because they have to do a lot of workarounds, right? They have to work around being able to get medications. They have to be able to convince people to do things for them. And so they know, what to do to avoid detection. What about addicts cannot recover and only need treatment for a couple of weeks? Is it possible for an addict to get control of that and to move on in life? Fake news. What do you think? So you guys have had some experience at clinical in like behavioral health and ACT. How easy is it to recover from an addiction? Stephanie makes a good point. They can recover, but it's usually a tough road, right? They need a lot of support. It's hard work every single day. They have to take it one step at a time. And I think what Stephanie, Kylie, were you going to say something?
Sorry, I just cut out a little bit, so I didn't hear part of that. That was all.
Okay. I think that Stephanie makes a good point, is that they might be able to have control over their addiction, but I think that they are always considered an addict. And why do you think that's the case? Yeah, because they can always relapse, right? They don't know what's gonna happen. And the thing that is scary about this is, when a person first starts, taking drugs or drinking alcohol, they usually start in pretty small amounts, right? On the low and slow side. But once they've moved up and they're drinking copious amounts of alcohol or taking large amounts of medications, once they get control over that addiction, and then if they do choose to participate again, they usually will go back and start where they left off. They don't go back to the beginning. And that puts them at high risk for injury and even death because their body has been without for whatever period of time. And then when it gets slammed with that high dose of either alcohol or drugs, it can be really catastrophic for that person.
Sorry, just like as an aside, so I worked on behavioral health for a couple of years, and we see a lot of alcohol withdrawal and opioid addiction and drug addiction. Mm-hmm. And I heard when I was working there that it takes someone an average of 8 times coming to treatment in order to finally like kick the habit if they're able to do it. So if you're working in that setting, it can be really emotionally draining when you're caring for those patients because you're just seeing it as a revolving door. Mm-hmm. But it's nice to keep in the back of your mind that like it can take it's an average of 8, so some people it can take 12 times, some people can do it the first time. So just still like remain compassionate about it even if you're like tired of it.
Sure. And you just have to look at it and be, it's admirable that they continue to come back and keep trying and that they want to be better, because I'm sure it's devastating to them and to their families. And so they really do, like Kylie mentioned, they need a compassionate person who's going to be there to help them and to be there as they go through kind of the worst times that they might ever have. There are different kinds of programs available. So short-term programs, they might be like 21 days. So I know like at the REACH, they have ACT and they can do like a quick detox where they're there for like 3 or 5 days, or they can do like an inpatient stay where it's about 3 weeks and they kind of, are there for that time. And they might go on to some more long-term care. It just is going to depend. But they will need follow-up supervision. They usually have, therapy in conjunction with what's going on. They have groups and things like that so that they can have the emotional support that they need in order to overcome these sorts of things. Nurses who remain in treatment for at least a year. So if a nurse either chooses to do treatment on their own accord, or they could be court mandated to do treatment, If they can be in treatment for a year, and that doesn't mean that they have to be like inpatient somewhere, but they're participating in some kind of program with, regular therapy and things like that, then they are twice as likely to be drug-free. But again, that struggle for recovery will last for the rest of their life. It will always be something that will kind of just be in the back of their mind that they could potentially pick up at any time. The 12-step program, absolutely correct. When I was in nursing school, I had to attend an AA meeting, and it was one of the most interesting experiences I ever had, to go and to see the people interact with each other and talk about what was going on and what step they were on and how it applied to their life. And it was pretty great. Okay, nurses caught using have to want treatment and can't be forced into it. What do you feel about this statement? Can you force somebody to get treatment? Yeah. They can go to, like, you could, I mean, the court could mandate and say, you will go to this, inpatient treatment and you will be here for 3 weeks. And they might sit in the hospital for 3 weeks, but if in their mind they're not going to participate, are they going to get better? No, right? So they need to want to make a change. And if they go into treatment on their own accord, I think that they will probably be more successful than if it's a family member who's saying that they need it, or, the court is mandating that they go, or the, nursing board is saying you can't have your license back unless you get some treatment, right? So it's them needing to wrap their head around the fact that a change needs to happen. I think that that's the biggest thing. Exactly. You can be admitted, like I said, you can sit there in the hospital for 3 weeks, but if you don't participate and if you don't, do the things that you're being asked to do, it's not going to be a benefit for you. So like if you choose to drink alcohol and want to come to work, there are ways that you can expedite that process. Are there things that you can do to get rid of the hangover and the effects of the alcohol faster? That's a hard no, friends. 6, what does that mean? Betos. Oh, I love Betos. So they're saying the bare minimum is about 3 hours, right, after drinking. And again, that's going to depend on weight, things like that. But it's just, don't go to work if you've been drinking. Call in sick or plan your partying, on days that you're going to have off. But just be cognizant of what's going on. Okay, so these are some of the reasons that people will choose to abuse. So they might have issues in their personal life that they just want to escape from. They just want to be numb and they just want to, not really have to worry about it. Stress, we talked about stress. So what kinds of stresses do you think that nurses have that other people don't have, other professions don't have? Okay, so yeah, the feeling that you're like, I don't want to kill this person. Like, I'd like them to be alive at the end of my shift. That could be a stress, absolutely. Staffing ratios for sure, right? If you don't have enough people to help. Losing patients can be really stressful. Yeah, giving and giving and giving and not really getting a whole lot in return can be emotionally draining, right? Family members of the patients can be stressful, right? We're not only taking care of our patient, but their family as well. So your own family members, right? So if your own, tribe isn't where they need to be, then that you can feel guilty for leaving and going to work, and then you're not really giving all that you have at work, and so it's just kind of this perpetual cycle. Oh yeah, you'll get a lot of that. I have always teased my friends and neighbors. I'm like, I'm just going to send you a bill, right? Yeah, those COVID nurses in New York, I'm sure that they have seen some really tough things. And they've had to be like the support person for patients as they are dying because their family can't be there. And I just can't imagine the magnitude of that responsibility. And so it would be really easy to say, I just need something to just forget about what's going on and just kind of not have to worry about it for a while. Yep, exactly. Social environments, that we're claim that we need to be self-reliant, we need to be independent, and we shouldn't, we should be able to do this by ourselves. We shouldn't need to ask for help if we need it. And so sometimes that can cause some extra stress. Sleeping, our sleep patterns can get all crazy, right? Especially if you're flip-flopping between day and night shift. Like you might need to take something to help you to sleep because you are unable to fall asleep on your own. And then just overall fatigue, right? Fatigue, I think, is a little bit different than just being tired. Fatigue is where like you actually just ache. Your whole body just aches because you're just so drained and you just don't have anything else to give. Okay, so these are some of the things that you might see, signs and symptoms of a substance abusing nurse. So I'm just going to cover a few of these here. One of the big ones, I think, is like obsession with the Pyxis. So, you're taking care of a patient and you need to get a med, and this nurse is like, oh, I'll run and get it for you, right? So they have an opportunity to shuffle around in the Pyxis. Discrepancies with the NARC record. How often does that have to be reconciled? You guys know? Every shift, right? Every shift, it has to be reconciled. So the charge nurse, the outgoing charge nurse and the oncoming charge nurse will usually go into the med room, and they are going to count and make sure that the counts are correct. What if they're not correct? Yeah, and then they have to investigate, right? They have to go back and say, this is what we're missing. Did somebody give this, or did somebody forget to waste? Or, they have to figure out. They don't wait. Oh, we'll wait till staff meeting and talk to everybody. It's like, no, who worked? Who was here? We need to find out what happened, right? You might see some physical signs where, maybe their gait is off, or maybe they've got some slurred speech, or you notice a change in their pupils, or all of a sudden they've had, either weight loss or weight gain. And maybe, they would come to work and they were always nicely groomed, and now they're a little disheveled like our previous friend. And you're like, what's happening here, right? Some other things, and this one can be a little tricky, like they're wearing cold weather clothing in the summertime, right? So maybe they have a long sleeve shirt on under their scrubs, but sometimes the units are just freezing, and so you would just wear that regardless. But that could be something that is being done to cover up track marks or injection spots or something like that. They are caught in lies, or they're not concentrating, or they have mood swings that are happening. Another one too are the unexplained absences from the unit. It's like you go to find them and it's like, where are they? And they're like, oh, I had to run to the ED, or I had to run and do this. And you're just like, what? There's no reason for you to be doing that. Or they go on break, or they go to have lunch and they come back and their mood is totally and completely different. Like they've taken something to kind of, get things going. So these are some things just to kind of keep in mind, right? Another one too that is a big one is where you have patients who are complaining of lack of pain relief. So like if you have a nurse that works before you who is diverting pain medication, right? The patients, once you take over their care, they might be saying like, I'm in so much pain, like I just am really hurting. And then, you give them the medication that they're supposed to get, and they make comments like, oh, that's just working so much better. I don't know what, the nurse gave me before, but it just didn't really seem to help. And so those sorts of comments are going to be a clue, like what's going on. And so basically what happens is there's a variety of ways that this can occur. Sometimes the nurse who's diverting will go into the med room and pull up the medication and inject it into themselves, and then pull up saline into the syringe, and that's what they give to the patient. Or they will pull up what they need for the patient, and then maybe there's something left in the bottle that needs to be wasted. And so then what they'll do is they'll pull up what needs to be wasted and put that in a syringe and put that in their pocket, and then fill the vial with saline for the amount of medication that should be wasted, call somebody in, have them waste. So everything looks just hunky-dory. It's like, oh yeah, they wasted, 1 mil of morphine. I saw the liquid in the bottle. I watched them throw it in the, sharps container. Everything's fine. But in actuality, that's not what was in that bottle. So there's lots of different ways that this diverting can take place. So don't always think that just like, for me, if I was going to waste with somebody, I want to be in the med room from the beginning of the process. I want to watch them pull the vial out of the Pyxis. I want to watch them draw up the medication they're going to give, and then watch them dispose. I wouldn't want to come in halfway through and have them say, here's the medication in my syringe, here's what's left in the vial, this is what I'm going to waste. And I wouldn't be okay signing my name to that because I just don't know, right? No, I've never had issues with that. I think that you probably could. And I think that there are sometimes where like nurses will know their friends like logins and things for the Pyxis. But it's your nursing license, right? And so it's just something that you don't want to just take lightly. I think that some med rooms might have cameras. I'm not exactly sure about that, Fernando, why that's not something that's more perpetuated. I'm not sure. I don't know if it's like a trust thing, or I'm not sure. I'd have to investigate that. But let me just tell you a quick story about this. So some of you might know Leslie Mock. Now she's the VP of instruction, but she used to be the coordinator of nursing. And she worked in the PACU, and she had this patient who came back to the PACU and wasn't doing so hot, and the patient ended up coding. And so they had to respond, right? They had a code blue, they were doing CPR, the anesthesiologist was there, the nurses were all helping, so on and so forth. They got the patient stabilized, the patient ended up going to the floor, and then the anesthesiologist came up to Leslie and said, hey, in all the hubbub, you broke this vial of Dilaudid. And she was like, what? She's like, I don't think so. He's like, yeah. He's like, and everything that was going on, you kind of bumped the table and this vial fell on the floor, and so we have to waste it. So I need you to sign, saying that it was wasted. And so she didn't love that idea, but it's like, here's this physician telling her this is what happened. So she signed. Big mistake, right? So fast forward a few months, she's called into this investigative board because this anesthesiologist is basically on trial for diverting drugs. He was addicted to Dilaudid. And so they were asking her what had happened. And so she told them, and they basically just said, don't ever do that again, right? Like she could have lost her nursing license because of that situation. So people might not like it. And all you have to say is, okay, fine, then find somebody else to waste with you, right? That's what it boils down to. If they're not going to do it the way that they're supposed to do it, you do not have to sign your name and be the person who is going to document that has been done properly. Okay, so again, if you suspect that somebody is a substance abuser, right? If you feel comfortable approaching that person, you could try that, but you need to go up the chain of command, right? Make sure that you are covering, yourself. You want to protect yourself and you're protecting your patients, but you also want that nurse to get help, right? And so this is why we educate you about this. It's something that has become more prevalent nowadays. Fun fact, I don't know if this is really a fun fact, but my grandma on my dad's side was a nurse, and she was actually a drug diverter. It's fun family history, and she ended up overdosing. And so she ended up passing away due to a drug overdose, and she was a drug diverter. And my mom told me that this was back in the day when they always wore white scrubs, and she would wear like a lab coat because she was afraid that when she injected herself that the blood would leak through onto her white scrubs and people would see it. So Kim, with that situation, I think if it was like a one-time thing, you'd probably have to have some, reconciliation done. I don't know if you'd need to offer to do a blood test at that point in time, but if this was something that was happening regularly, then I think there would be an investigation. But it's really hard for you not to be able to do it because you're prompted, especially in the day of the Pyxis, right? You are prompted so many times to waste. And so, when you take it out, it's going to tell you to waste. It will always stay there as kind of a red flag, as something that needs to be taken care of. So every time you log into the Pyxis, it's going to say, did you waste this? So I think if it was a one-time thing, I don't know exactly what would happen. They'd probably make you go, I don't know if you dig through like the garbage. There was one time at clinical where I saw this poor nurse like tearing the garbage cans apart because she had thrown something away that she shouldn't have thrown away. And so, I don't know. Oh, the vial of Dilaudid. I don't think that they were concerned that Leslie had taken it herself. I think that they knew what was going on and they were just like putting their pieces of evidence together. Like they didn't assume that they weren't saying that she had taken it and had, actually used it herself. So that was kind of the situation there. Okay, so these are just some articles. So there was a nurse, I don't know if you might remember this, but she actually worked at Davis Hospital and then she worked at McKay. And she was drug diverting and she ended up infecting a bunch of patients with hepatitis C. They were able to figure out what her exact serotype of the hepatitis C was and then match patients that she had infected based on what, their genome of hepatitis C. And so it was a big deal, right? She went to trial. I think she had criminal cases and civil cases that went against her. Her nursing license was stripped. I think she actually surrendered her nursing license because she just knew that it was over. Yeah, it was crazy, right? And so who has to pay for the treatment? So she gave them, so hepatitis C is transferred via blood. So she was injecting herself and then using the same needles to inject her patients. So that's how they ended up getting it. And so who has to pay for the treatment of those patients? Why was she doing it? Who knows, Maya? She was crazy. The facility has to pay. And then there's the risk too that people didn't come in to be tested, right? Like, so they might have gotten the letter that said, you could have potentially been exposed. We need you to come in and be tested. And then if they weren't tested, then they don't know if they have it and they could potentially be spreading it around to other people. So it was a huge fat mess, like a big, big deal, right? One of the articles talks about an anesthesiologist who came in to do a surgery who was impaired, who ended up killing a child. I want to say it was like 6-year-old who was coming in for a TNA. A TNA, tonsils, to remove tonsils and adenoids, literally takes like 15 minutes. Well, he was so impaired that he didn't know what the heck he was doing, and the kid ended up dying on the operating table. So there's a lot of situations here where, it's very problematic. And sometimes in healthcare, we want to protect our own, right? Like we don't want them to, to have that backlash, and we don't want to think that something like this could have happened, but it is happening. And so we just need to be aware of it and know what's going on. So that's pretty much it. So you can actually go to Doppel and you can look up, if you look up this lady's name, her name is Alette Nielsen. And you can go to Doppel and put her name in and you can see like all of the court cases and the documentation on her and what happened and that her license was surrendered. It was a big mess, right? So the moral of the story is don't do drugs. You can't hug now because of COVID. Maybe just give an elbow, but don't do drugs. Dare, exactly. Okay, so for this little presentation, there's a little quiz that I uploaded into Canvas. It's like 10 questions. You can use this. There's also an article up there about drug diversion. Just true, false, just answer the questions, re-upload it, and you'll get your learning activity point. It was good to be with you for a few minutes, friends. I hope PN2 is treating you well. Clinical starts next week. It's going to be fab. Are you so excited? I'm excited. I did get a haircut. Did you see? I had to do something a little more festive, right? Thanks. A little sassiness, right? I thought when Mark said something about short hair, don't care, I'm like, is he talking about me? Does he feel like I am eluding that attitude of I have short hair now and whatevs? Thank you. My school is going well. A lot of discussions. I'm like, we've discussed this to death. Huge. I love you. I miss you too. Kim, it's fine. It's happening. You're going to do it. It's going to be amazing. All right, guys, I'm going to turn you back over to Corby. Corby, are you there? Corby, are you there? Anybody? Bueller? Oh, there she is.
I'm here.
Hey, I'm done. Do you want me to? So I don't know how you want to proceed. Just take back over control.
Yeah, I think we'll take maybe a 10-minute break.
Okay, go potty.
Nah.
No drugs. Maybe have a popsicle or a cookie instead. I promote that.
Do some jumping jacks, get that blood flowing.
Do your sit and be fit, friends. Mark, yoga, that's kind of sleepy. Get your sweatband on and do some sit and be fit.
Yeah. So we'll take a 10-minute break, come back at 10:40, and 13-minute break, I guess.
Hey.
And then we'll start into Unit 1.
Fabulous. See ya.
Thanks, Rach.
Yep.